Hello, everybody. My name is Dr. Carly Day. I am a physician from the United States of America, and I am recorded today to present at your conference. I appreciate the invitation. And my job today is to speak on the roles of non-surgical sports medicine physicians and athletic trainers in the United States. I am a head team physician at a large university in the United States. I also serve as the first vice president for the American Medical Society for Sports Medicine. So when we look at sports medicine physicians in the United States, I want to take a step back and just explain sort of the medical path in the United States for those that are not familiar. So we attend after high school, after secondary school, we attend 4 years at a university, then another 4 years in medical school, and then we will do a residency in the specialty of our choice that can be anywhere from 3 to 6 years, followed by fellowship for those that choose to do so. I would like to focus on this residency time when it comes to sports medicine. So there's 6 different residencies you can do in the United States and become a sports medicine physician. But there's orthopedic surgery, and then I sort of lump it into all the other 5. So if we go to orthopedic surgery, those folks will do an orthopedic residency, and then they can do a fellowship in sports medicine, which for us typically is arthroscopy of the shoulder, knee, and hip. But you can also do a foot and ankle fellowship and then work with athletes and deal with their foot and ankle issues, but usually that won't be your full-time job. That will just be someone who also sees athletes. When we look at the 5 other specialties, family medicine, internal medicine, pediatrics, physical medicine and rehabilitation, and emergency medicine. In the United States, anyone who does any of those 5 residencies can then do a fellowship in sports medicine and become a sports medicine physician. And so it's interesting because they have different backgrounds. Going back to orthopedic surgery, there's pros and cons, and I think the people in the United States who go into orthopedic surgery find it fun. They like that it's procedure oriented. They get to subspecialize in the musculoskeletal system. They do make more money than non-operative physicians, but there are some potential cons as far as long work hours, high pressure stakes, being a surgeon, and then also just less time with athletes. So in the United States, a lot of the people who spend more time with athletes are those primary care or non-operative sports medicine physicians. In that world, in the non-surgical residencies, each of those 5 has their pros and cons. And so you have your family medicine, internal medicine, pediatrics, which we would call our classic primary care residencies. And obviously there's some differences as far as the exposure to intensive care time and age groups, but they really focus on that primary care medicine. Physical medicine and rehabilitation is a 4-year residency with a lot of exposure to musculoskeletal medicine, but also some medical aspects as well. Learn also about adaptive sports, brain injury. So a lot of that can apply to sports medicine. And then emergency medicine, a lot of them are great at those really acute traumatic injuries, mass event coverage. So any of those can go and do the same fellowship, right? So they all are applying for the same fellowship and get accepted based on, their interview. And then the fellowship's job is to really elevate them. So when we talk about this fellowship in sports medicine, it's actually only a 1-year fellowship, and it is optional, but frequently done for physicians who are taking care of athletes at the professional and collegiate level. So this fellowship that we typically do, obviously there's just elevation of musculoskeletal care, getting better at fracture care, injections, ultrasound, spending time with surgeons to understand how they work. But then there are also components of research, concussion management, medical issues in athletes, training room coverage, sideline coverage, and then a continuity clinic where that physician sort of functions on their own with just some mild supervision on the side. When we look at the numbers and the membership within the 2 major sports medicine societies in the United States for physicians, AOSSM is the Orthopedic Sports Medicine Society and AMSSM is the Non-Surgical Sports Medicine Society. And currently the non-surgical side actually has increased to greater than the orthopedic side. If you can look at this graph right here, the black line is total membership for AMSSM, and over the past 20 years, it's risen from less than 1,000 to, this is a couple years out of date, to now over 5,000. So very significant growth in that field just in the recent past. Now, when we look at the demographics of who these people are, as far as sports medicine physicians in the United States, AMSSM, our non-surgical society, is about 30% female. The Orthopedic Society of General Orthopedics is 6.5% female. But one thing to look at, maybe parity, gender parity is coming, is that orthopedic residents are 14% female. So it may be down the line that we do see more women in orthopedic sports medicine. Within the non-surgical subspecialty, and we say, okay, there's 5 different residencies you can do. How does that break down? So the majority are still family medicine physicians, but there is some growth in the physical medicine and rehabilitation, pediatric side, as far as what % of members are coming from those residencies. And then internal medicine and emergency medicine give the smallest proportion of members. When we go to the college side, so college team physicians is a great role in the United States. Again, it's what I do. There are a lot of universities. If you look at all divisions, over 1,000 universities that do have to name a team physician, a head team physician. Within those, and specifically Division I, which is our highest level, our most competitive, that's the one you'll usually see on TV. 90% of head team physicians are male, while only 10% are female. But interestingly, amongst the male physicians, it's about half and half who is ortho and non-ortho, whereas for the female physicians, the majority are actually non-surgical. So only 1% of Division I college head team physicians in the United States are female orthopedic surgeons. So it seems like there's some difficulty for them breaking through into that role. Now, switching over to athletic training is really important in the United States, and they serve a role to take care of athletes. Their big society, which is the National Athletic Trainers Association, or NATA, actually has 45,000 members, right? So that's a lot higher than the physician societies, and 79% of those members are board certified. When you look at the setting, so 25% are students, but when you take them out, it's a pretty evenly split between athletic trainers working at the college level, working in secondary schools. So again, that's high school right before you go to university, and then working in a clinic or a hospital. So they can be in lots of different settings, but this emerging settings category, which right now is only 2%, but it's called an emerging setting because it is increasing. There's a lot of different roles for athletic trainers. Especially in this public safety sphere, so fire and police and emergency medical systems, a lot of those groups can hire an athletic trainer to work with their, policemen and women on injuries, on getting them back to work. And it really actually saves the department some money because it can keep their employees active. The military is also a role in the United States that athletic trainers are just starting to break into. There was actually a study looking at athletic trainers in U.S. military settings, and it was found to decrease attrition due to musculoskeletal causes by 25%, and they had 16% lower stress fracture incidence. So that's very significant. And for these athletic trainers, it gives them the ability to have more standard work hours. Obviously, from sports coverage, a lot of those athletic trainers have early mornings, late nights, whereas when you work in some of these roles, you can have more of a typical work day. And some of those do get better salaries in these roles, but it just sort of depends on how far along you are in your training and what the offer is. And I put less conflict with a question mark. Some of us know in sports medicine, it can be challenging to work with coaches or administrators if there's some pushback as far as why an athlete isn't playing. And I think in those emerging settings, there's maybe a little less pushback, but still, I'm sure they still want the police and fire folks to get back as fast as they can. Secondary school. So again, this is that high school setting in the United States. It's interesting because it's split about a third of schools that do not have an athletic trainer. So about a third do not have any athletic trainers in their school. So it's not guaranteed to have one. About a third have a part-time athletic trainer and a third have a full-time athletic trainer. So in the United States, it's not that every high school or secondary school does have an athletic trainer present. There's a little bit of a difference there. And unfortunately, a lot of that does go by socioeconomic status. So this study shows that those schools that have the upper third median household income are likely to have a higher AT availability, higher hours per week that they are designated to that school. The athletic training education in the United States, historically was an undergraduate 4-year degree, and then they would take a certification exam. But in 2013, their association decided to switch to a graduate level degree. So now it's 4 years undergrad plus a 2-year master's. And some of the thought that it's been explained to me for that change from undergraduate to a master's degree was try to get back on par with some of the physical therapists, occupational therapists, speech and language pathology, hopefully for pay parity, but also just to have that respect of being a professional and having a postgraduate degree. Still to be determined if that will make a difference or not, but we have now switched over to all athletic trainers needing a master's degree in the United States. So salary wise, I know sometimes this can be a little controversial. I just took the average salary from a website in the US and then put it in a Google form that switched it over to the Indian rupee equivalent. So in the United States, athletic trainers still make a significant amount less than even physical therapists, physician assistants. And then primary care, sports medicine physicians, and orthopedic sports medicine surgeons do make more, but you can see that the orthopedic surgeons make, twice as much as the primary care sports medicine physicians. So what I wanted to do is give you a snapshot of what my role is. So I am the head team physician of a university. Its name is Purdue University. If you look at that map of the US, that red state is Indiana, and that's the state that I'm located in. Our football stadium there in the upper left is called Ross-Ade Stadium. We have a capacity of over 60,000 people that can go to our football games. The football training center was a $65 million training center built a few years ago in that lower picture, but that's for football only. So we still have a whole nother set of facilities for all of our other sports. We have soccer, basketball, volleyball. That person in the lower left is David Budai, who's an Olympic diver who used to dive for our school and now coaches for us. So my university specifically is 18 sports. There are some that have as high as 30 or 30 plus sports at their university. We have 16 athletic trainers, 3 of which are dual credential athletic trainer and physical therapists. And our American football team has 5 athletic trainers designated just to them. So there's over 100 athletes. It's a sport that does tend to get a lot of injuries. And so there's 5 athletic trainers there. Track and field has 2 athletic trainers assigned to it because it's a larger team. The men's and women's teams are combined. And then some of our other sports tend to have a 1-to-1 ratio for 1 athletic trainer for 1 sport. Athletic trainers in the United States do have the ability to get credentialed in dry needling, phlebotomy, suturing, and making orthotics. And not all of them do all of that, but they can sort of get some extra skills there. We also, as part of our team, don't just have athletic trainers, but we do have mental health clinicians. My university has 2 full-time psychologists and a part-time psychiatrist who works in conjunction with the team physicians for mental health care. And then occasionally we will use outside resources if someone needs a residential eating disorder admission or significant substance abuse. Dietitians also contribute significantly at our university. So we have 5 full-time dietitians just for our student athletes. They each are assigned to multiple teams and they help so much. So individual counseling with the athletes, in addition to team meal planning, we do have an athletics only dining hall that they help run. Fueling stations are like the snacks that are on the weight rooms, and then help athletes with hydration, especially the outdoor sports that can deal with heat. Now, our strength and conditioning professionals, we have 15 of those for our 18 teams. Again, football has 5 dedicated just to them. And then other strength and conditioning coaches may have 1 or multiple sports. And they help athletes in the weight room with performance and return to play. So you can see how big our sports medicine team truly is just at this one university that I work at. From a physician standpoint, so we have two full-time non-operative physicians. So I am the head team physician, I'm PM&R, and I oversee policies and all medical care and also see athletes in the training room. And then our second team physician is trained in internal medicine and pediatrics. He's the primary point of contact for football, but then also helps with other sports. And then we have multiple part-time physicians from varying backgrounds who might cover one sport or come by once a week to help in training room or help out if myself or the other full-time physician are out of town. And then we get to our orthopedic surgeons. So we have three orthopedic surgeons who come to our campus. So one is an upper extremity surgeon, then a knee surgeon, and a foot and ankle surgeon. Sometimes they come to football games, they do weekly training room. And then we have other specialists like spine or hip that they don't come to campus, but they have made themselves available to us where we can get someone in quickly to be seen if needed. And so when you look at what the schedule is, there's essentially sports medicine, non-operative sports medicine available every day during the week and on call on the weekends for these athletes. And then again, our orthopedic surgeons might come once a week and run a training room just to see the injuries that are specifically referred to them. And the coverage for physicians can vary a little bit. Sometimes physicians are just assigned to a specific sport and they only take care of that sport. Sometimes they split up coverage and just any athlete can see any physician. And then a lot of colleges now will have a hybrid model where physicians are assigned to sports, but patients can also be triaged based on area of expertise. So for example, I take care of all the eating disorders at my university. So if there's an athlete that I don't cover their sport, but they have an eating disorder, I'm usually going to be involved in their care. Whereas other physicians might be more specialized in PRP or ultrasound guided injections, and athletes may get referred to them. So not all universities are the same. So again, I'm currently at this Division 1, bigger budget, more competitive school with 550 athletes, 16 athletic trainers, 5 dietitians, 8 plus physicians, 2 psychologists. My previous role was the head primary care team physician for a Division 2 school that had 750 athletes, so more athletes, and only 4 athletic trainers, no staff dietitians, no staff psychologists, and 2 part-time physicians. So really in the United States, it can vary significantly. And I just wanted to give you a little idea of what my setup is like at my university. So I hope that was helpful. I do have references here, and I'm happy to answer any questions that are sent my way through your conference. But I appreciate your time today, and I've really enjoyed giving you a peek into the world of sports medicine in the United States. Thank you so much.